I want to welcome everybody to our program. This is the ethics of dementia. We are going to be getting ready. Chera Inhat and Linda Bliss are going to be talking about all the issues, ethical issues that we have going on with dementia. And so we'll get started. So go ahead, Linda and Chera.
Okay, do you want me to start, Linda?
Sure.
So thank you guys for joining us today. I'm Chera Inhat with Kemper House in Highland Heights, and I have Linda Bliss, who is an RN and was our nursing director for many years and is an author. We are going to talk to you about some of the ethical challenges in our experience in the last 20 plus years of working with folks with dementia. Some of them we really had to rack our brains, Linda, didn't we? Things you wouldn't even think about might be an ethical issue, or things that we think is okay, or things that are borderline, but we feel they're okay. So we're gonna go more into detail about what some of these issues are.
Okay, you want to go to the first slide? Yep. These are some of the ethical dilemmas or issues that we face every day. And certainly Chera and I have experienced most of these with family members. We also do CEU presentations for social workers, nurses, and other healthcare professionals. And under the topic of what would you like to see or hear about, often they have put they would like to have in-service or CEU program on ethics. So that's what got me interested in putting this program together. Plus, recently at Ursuline, I took an ethics course, and I found it very exciting and interesting, and I want to share some of the thoughts that I learned. So we'll go beyond this, because we have found that giving this lecture a couple of times, it goes much longer than an hour, and we only have an hour today. So go to the next slide. First of all, what is ethics? It's a term used for exploring human values. Constitutes what is good and moral in our life, and it approaches to ethics examining what is considered right or good in a particular cultural context. And I say cultural context because not all cultures have the same ethical standards. It's important to know that there are 4 principles of medical ethics: autonomy, benevolence, non-malevolence, justice. Ethical dilemmas arise when there are equally compelling reasons, both for and against a course of action. So you may want to ensure this patient or person's autonomy, but by doing that, you're not always doing what is the ethical thing to do, and I'll explain that later. You want to go to the next. The 4 principles: autonomy, that's the right for an individual to make decisions about their own health care and their own life, and the right to maintain a sense of self and a way to express values. Now, ethically, the dilemma comes when this person no longer has safety awareness, and they don't always have the cognitive ability to make the right decisions. So we're already unable to give them autonomy. But what we want to do is act of being kind. The concept is closely related to the concept do no harm. It means actions of practice that are in the interest of the person and avoid negative consequences. So there's another dilemma. Does the means justify, does the end justify the means? If the end turns out in a positive way and offers the person the most beneficial, does the means of getting there, does it have to be ethical? This is a dilemma. There's a means to not do what might be harmful to someone. And then justice is the fair distribution of benefits and burdens. Justice is the degree to which healthcare services are distributed equally throughout our society? Do we always distribute the healthcare services equally to people who have dementia or other types of illnesses? We'll look into this a little bit further too. A person with dementia, how does this ethical issue or these dilemmas affect them? They have a feeling of being devalued. They're labeled. They have dementia. Because of their cognitive disabilities, they're at risk for abuse, financially and emotionally, and psychologically, physically, and sexually. Persons with dementia, especially in the early stages, are very frustrated. And the frustration of being defined by dementia. They know something's wrong. In fact, I had a gentleman that the wife was telling me, he came downstairs one morning for breakfast and said, I have to call the doctor. I have Alzheimer's disease. He said, why do you think that? And he said, well, I know I have to shave, but I can't remember how. I can imagine how frustrating and frightening that can be. They tend to have a social isolation. Not only the person with dementia, but their loved ones. Friends stop asking them out to dinner or over to their house. A lady was telling me that her husband played tennis up until he was about 90 years old, but his friends stopped asking him because he couldn't remember a lot of things that involved in playing tennis. Of course, they lose their independence, and all this has them a loss of autonomy. Family, how does it affect family or healthcare providers? Well, healthcare providers don't really want to take away the independence of their loved one with dementia. They really have no choice. They need to promote autonomy. It has to be balanced against the need to promote well-being. And this is a real ethical issue, and it's a dilemma, because to promote autonomy and balance it against the promotion of well-being, one of those is taking away the driver's license. A person with dementia are not told, personhood, a person with dementia is of equal value to persons without dementia. Does everyone in society believe that, or is that an ethical issue and an ethical dilemma? All right, we're going to go into what some of the ethical issues are. One of those is, do you tell someone that they have dementia? And when do you tell them? In certain cultures, especially in the Orient and European, Southern Europe, the family is told of the patient's diagnosis, but the patient is not told. They are protected. And I asked a doctor that I know really well, do you tell your patients that they have dementia? He said, no, not always. I said, you tell them if they have a terminal illness, because we know dementia, Alzheimer's disease is. He said, no. He said, I'm afraid they'll give up. Now, is that an ethical issue, do you think? Because we are told that in order to have informed consent for any type of treatment, you have to be told everything about that treatment and that medication. And that means that you need to know what your diagnosis is and why you're taking that medication and the treatment. And since there's no cure, physicians believe that it could be detrimental. And like I said, the physician that I know said he's afraid that they'll just give up. Genetic testing has become a huge ethical issue. How much knowledge do you want, and what are you going to do with it? What is your family going to do with it? The company that's doing the genetic testing doing with this information? More than half of the people with dementia
Sorry.
told about their diagnoses. Did you want to add anything to that, Chera?
So we have had families that are like trying not to tell their loved one. I don't know. I feel like if it was me, I would definitely want to know what I had going on, no matter what it was, whether it was dementia, something terminal. But a lot of families struggle with that. I don't know. It is an ethical dilemma. But I feel that they should communicate that.
Well, I certainly would want to know. And
You
if
would
I
want
had
to know? Yeah, you
if I
would.
had a terminal illness, I would want to know.
Yeah,
But not everyone does, I guess.
yeah.
All right. Another ethical issue is undertreating. Just because someone has dementia, do families feel that maybe certain treatment or medication is going above and beyond? I know a lady that lived with us and a mentor was diagnosed with breast cancer, and the family decided not to have surgery, to have any radiation or chemotherapy. She was put on an oral, I believe was the name of the medication. But of course, if she had been, if she did not have Alzheimer's or any other type of dementia, they most likely she would have been able to make that decision. I don't know if she would have chose to have surgery or not. But this is a dilemma that the families face when their loved one no longer has the ability to make these decisions. Fair distribution of benefits and burdens. To promote and sustain the person with dementia. Is there a fair distribution of benefits and burdens to sustain the person with dementia? Withholding food and drink. This is under treating. Fortunately, we do have an order for comfort feeding only. And in our facility, we have liberal diet on special occasion. Withdrawing or withholding medical intervention or life-prolonging measures. Consider the net benefit, doing good for the patient. So maybe withholding surgery for breast cancer is doing good for the patient. But this is a dilemma that we all face, especially when families are making those decisions. We had a gentleman with Alzheimer's disease, and his daughter was power of attorney, and she felt assisting a full assistance with hand feeding was considered a life-prolonging intervention because the gentleman could not feed himself. So she wanted them to withhold any type of fully assisted hand feeding. And the staff in hospice, of course, are not comfortable with this. So fortunately, there again, we have the feeding for pleasure or feeding for special occasions. Our healthcare system really is not set up to support some decisions that people may want to do. And how do you resolve this ethical dilemma?
You know, I had to actually talk to a family member who asked us to stop feeding their loved one because he had declined. And I told her that we could not do that. It would be considered neglect as long as he was eating, like wanting the food, taking it in and chewing it, you know, that we had to continue to try to feed him. And that if he were to close his mouth, refuse the food, turn away and not want food anymore, that would be a different story. But as long as he was actively participating in eating, that we had to do that, and she understood.
Right. Do you want to go to the next slide? Well, we can overtreat. Say a patient or a person, resident is not eating. Family, even though the resident was 93 years old and had advanced directive and did not want a feeding tube, the son is aware of these directives, but wants her to be kept alive as long as possible and wants a feeding tube. And he really truly believes he's acting from what he believes to be the best course of action. However, he expressing his opinion and neglecting to consider his mother and what she wanted. And this is definitely an ethical dilemma. Sometimes people will say, I know that's what mom wanted, but I don't want her to die. And I'm not ready to let go. Which is very sometimes difficult to sort out what is the best thing to do.
Yeah. I would say 99% of our residents over the years have all had DNRs in place because it goes hand in hand with what they want in their living will. But we always have a handful that want all measures taken. And it's hard. You got to look at the quality of life and everything. It's really hard to make that call.
Confidentiality is a huge issue. Genetic testing, we talked about that a little bit before. And there is a gene now that they can isolate. And so then this causes the problem for the family, the children and grandchildren. And some people have even, we had a gentleman, he was in his late 50s or maybe even early 50s. And his son, who was in college, he said that he was never going to get married and have children because he wouldn't want to put them through what he and his mom and family have gone through with their dad. So people make a lot of decisions based on the genetic testing and the blood tests that predict the development of Alzheimer's. There again, who should have access to this information and what do you do with it once you get it? Posting pictures on social media. I'm going to go to the next slide because I think it explains that a little bit better. There was a nursing student that in her clinical rotation was at a nursing facility, and she took an attachment to one particular resident and took a picture of her and this resident and posted it on social media. A friend of the family saw the picture, told the family, and the family called the nursing facility. They called the dean of nursing. And even though this nurse, student nurse, had no intention of doing harm or invading residents' privacy, the nursing student was expelled from school. Do you think the punishment was justified?
I think the overall consensus when we did this program a week ago was a little bit harsh, but I guess everyone has a different opinion.
Yeah. I mean, she didn't mean any harm. So other than privacy, which is a huge thing in the medical profession, there really wasn't harm done. I never considered this in the 20 years that I've been working with folks with Alzheimer's disease. I never considered electronic tracking in one regards an ethical issue. There seems to be so many positive things about it. It really does enhance their safety, and it is the least restrictive method of managing walking and wandering. They even have electrical tracking devices that you can use at home, and this will keep the patient safe or the person. And it inherently is an invasion of privacy. You know where they're at all times. It implies that these people with dementia are irresponsible and need constant surveillance and supervision, and it does create a stigma. So it's very difficult to balance the rights and risks of the resident, and certainly the autonomy. It's a huge issue. It's like taking their driver's license away, and we're going to talk about that in a little bit.
I think that maybe you have to worry about here how that person wanders. I know that when I was a child, we found an older woman wandering down the road in her nightgown, and she didn't know where she lived, and it was a safety issue for her, and so we picked her up and we took her to the police department because we didn't know where she belonged, but like if the safety issue is that she was on the street walking, in the middle, kind of in the middle of the road, and my family was like, we have to fix this, but we didn't know who she was. We didn't know where she had come from, and she didn't know where she had come from, so if the person has a tendency to wander like that, I think you almost have to do some kind of tracking in order to make sure that they stay safe. But then
Right,
you have to balance, you know, safety versus invasion of privacy. And I don't know how you do that.
I totally agree with you. The Alzheimer's Association has a safe return program too. And it's either a bracelet or anklet, bracelet, necklace, but it has all the information on it. There's a phone number and it has all the information. When you call that phone number, they can tell you the name of the person and everything you need to know about them to get them back home safely. There again, it's the family's responsibility to ensure that these people are safe. And that's a huge responsibility. It actually consumes your life. But that, you know, for to find someone like that out walking around, you know, you wonder, has the family done anything to prevent this, or she should have had some sort of identification on her. Even with the police, when I do police and fireman training on dementia, and they say that I'll get a call from Erie, Pennsylvania, that someone, and it's their license plate, actually, they can give them or their license, driver's license. They were going to the mall and they turned the wrong way on 90 and ended up in Erie, Pennsylvania. So because of the driver's license, they were able to at least call the Mentor Police Department and get this person home safely. But it does take away some of the autonomy, for sure. Is it okay to lie to someone with dementia? Morally, it's important for all of us to tell the truth. Ethically, there are reasons for lying. Is the concern for the well-being of the person with dementia. Distract them from an upsetting situation and protect them from harm. We need to learn to edit ourselves and the information that we share. And this is a gift for both of us. We also call it compassionate deception and therapeutic fibbing. We had a lady that she sundown around 4 or 5 o'clock in the afternoon. She'd start asking where her husband was. And was he going to come and get her pretty soon? He knows where you're at. He knows you're safe. We haven't heard anything, so he must be all right. And then we would redirect her. We'd say, we're getting ready for dinner. Would you fold these napkins for us or help us set the table? Well, evening, another resident looked at her and said, he's dead. Will you stop asking? Well, with this, started sobbing hysterically. Don't you think I'd know if Fred was dead? Don't you think I'd know that he passed away? Did I go to the funeral? Who took me to the funeral? Where's he buried? She was absolutely inconsolable. Now, do you think it was more ethical to tell her the truth and to do a compassionate deception, a therapeutic lie? What would you do? Do you always tell your loved ones the truth through your clients?
We have families that still struggle with this, even though their loved ones in the past the mid stages. Most people get it, but some people still struggle with it.
Well, I did a lecture down in Metro Hospital several years ago, and there were social workers and clergy, and this chaplain raised his hand and said, why is it all right to lie to someone with dementia when we've always been taught to tell the truth? I told him, I said, our truth is not theirs. You have to get into their world. Now, if someone said to me, my husband's dead, isn't he? They already know that. They're looking for validation that what they believe is true. But when they say to you, where are they? They believe that they are still living. And you have to get into their world where they're at. You can't successfully bring them into this world. It only causes aggravation or frustration, or in this case, sadness. I would never want to cause anyone that kind of sadness. So you have to get into their world and what their truth is. In her case, Fred was still living, and she just wanted to know when he was coming to get her. We had a lady, this actually happened at one of our facilities. She'd been living with us, and before she was diagnosed with Alzheimer's disease, she was the caregiver for her son. He was about 54 years old with special needs, and he passed away. And two siblings decided not to tell their mother. The siblings felt the agonizing truth would be awful for her, and bringing up the reality of his death served no purpose. And do you say this is ethical or unethical? Withholding the truth from someone is just like telling them a lie. There again, it's an ethical dilemma, and I totally agreed with them that there was no reason to cause her the agony in losing her son. Does anyone not agree with that? Would you want to know if you had Alzheimer's disease that your son wants to outlive their children? Huge issue. This is probably one of the biggest issues that families face. And it often is one of those indicators or events that says something's wrong. I always ask family, how did you know something was wrong? What was the event? It's just like the lady that told me that her husband told her when he came downstairs and said he couldn't remember how to shave. Driving is a big issue as far as this the event. They were in a car accident. They got lost. Getting lost is huge. So it's up to you as a caregiver or the family member, the power of attorney, to decide when is it too dangerous. Are you going to wait until they have a serious car accident? Should the family be guided by the principle of autonomy, and that would allow them to drive, or by the principle of non-malevolence? Do no harm. I would like to think that I would be swayed to do no harm, even though you take away their autonomy. I was on my way, I ran a car to go to Florida. And when the driver picked me up to at the house to get the car, he said, I just picked up a gentleman at the senior center. And I asked him, are you going on vacation? He said, no, I just like to drive once in a while. And I said, do you know what's happening here? And the driver said, no, what? I said, well, his family probably took his car away. So he just figured, well, as long as I got my driver's license, that's all I need to rent a car. So you're letting someone drive who probably doesn't have permission from his family. So they can be very clever sometimes and find other ways. You have anything to offer, Chera?
Well, just that we also have had situations where we had someone years ago who attended the support group and said that, you know, their loved one had gotten in a pretty serious car accident where other people's life was actually put at risk. I mean, they could kill somebody else. And, you know, some of these families, we have residents move in who are driving up until a couple weeks before. It's kind of scary. You really have to think about, you know, how it's going to affect not just your loved one, but other people, innocent people.
Right. Okay. Hiding medications in food. This is called Covert Administration. I would guess 60% of the residents in nursing facilities refuse their medication. You're trying to poison me, my physician, my doctor didn't order that. I need that stuff. So we have to get clever as nurses. And we usually crush the medication and put it in pudding or applesauce or Someone one time told me that what works for one of her residents is Fruit Loops because they're different colors and they don't see the crushed medication. So is this an ethical consideration? Or is this what is best for the person? Well, I think so. I don't think physicians realize how difficult it is to get folks with dementia. And there are some pills that should not be crushed. The medication and the administration of medication is a very difficult thing when it comes to people with dementia. My father-in-law, my mother-in-law would at the breakfast table would say, "Here, Mike, take your medication." He said, "Well, just put it on the table." No, just take it and let's get it over with. And I'm sure, even though we were visiting, this probably happens every morning. And he finally held out his hand and said, "Here, give them to me." And he did, and he threw them clear across the room. You have to get a little bit clever. One thing for sure, there was no medication that had to be taken exactly that moment. So she probably could have waited and tried again. But there again, you know, when you're caring for people with loved ones with dementia, it can be very difficult and frustrating. In certain tasks, you just want to do it and get it over with.
Anti-psychotic drugs. So I can tell you about this. We've had families come to us and they see all those wonderful commercials that tell you all the different reasons why you shouldn't take the medication. And it's really hard because they think, I mean, the way the benefits usually outweigh the negatives, but some of the medications that can really improve someone's quality of life can also contribute to more falls or fractures or strokes. And usually those side effects are a very small percentage, usually, if you really look into it. But so why do psychiatrists continue to prescribe these dangerous drugs? I mean, we've had some families who just didn't want them to take it anymore. And even if their whole quality of life or their, you know, behavioral situation significantly changed just because they were worried of the side effects. So,
well, and I say aren't really used for people with dementia. It's not for the dementia, it's for the behaviors associated with dementia. So one thing that's interesting is when the state surveyors come in for your annual surveys, one of the tags or the things that they look at is the amount of anti-psychotic drugs that you're using. So they recognize it as something that's not really appropriate. So is it ethical for a nurse to even administer these medications, even though they're prescribed by a physician? I know when I was in nursing school, and I practiced it all through my career, is that if you don't feel comfortable with a certain treatment or a certain medication, especially in ICU when everything that we gave was IV. There was one physician that wanted us to do a certain IV bolus, which I felt uncomfortable with, and so did the other nurses. We would have rather just hung it as a drip. But anyway, you have that right as a nurse if you don't feel comfortable or you think it's ethical, but unethical. So should a nurse refuse to give a particular antipsychotic drug? I did a paper when I went to get my RN to BSN on using non-pharmaceutical interventions like validation techniques, music therapy, baby doll therapy. There's all kinds of non-pharmaceutical techniques that we can use that we're probably not using. That would be something that I would look at if I were doing a study. Go ahead, Chera.
yeah, this is a tough one. Thanks, Linda. So How do we protect the right to engage in meaningful sexual activity but prevent someone from being taken advantage of by another? So we have had several situations where residents have gotten like coupled up, like got a boyfriend, and I had to call the family and make sure both families approved of them having an intimate relationship. But I really feel like in most of the situations, it was more just boyfriend and girlfriend. I don't think, anything really beyond that. I mean, there has been a few situations. We had a husband and wife who wanted to still be intimate with each other, and they lived at the facility. And we, of course, gave them their privacy and made sure there were, staff knocked before they went in, or, things like that. We also had a lady who came to our support group. Her husband lived at Kemper House and was still very, early stage, very mobile, and was wanting to be intimate with his wife. So we had a talk. She's like, I don't know, would it be wrong for me to do that? He's a grown man and, he's saying he wants to be intimate. So she made arrangements to pick him up, every couple of weeks, and they would go to a little bed and breakfast and have their privacy. And we assured her that, that would be totally fine. They were a husband and wife, and they, if that's what he was wanting, like, it's a hard conversation to have sometimes, and you feel it's a little embarrassing to talk about it with people, but it's something that's very natural. The diagnosis of dementia does not prevent someone from being able to consent. You have to see, like, is there someone who, is showing that they don't want to be doing that and someone's forcing it on, that would be a different situation. But it's basically an important factor for maintaining quality of life for a lot of people. So it's something that can be very, very okay. Or, I haven't seen too many situations where it was, something that wasn't okay, at least not in the facility, but I've heard people, stories, but we haven't had to deal with anything that we felt was really inappropriate. Wouldn't you agree, Linda?
Right. I know in one of our facilities on the west side, unfortunately, the gentleman was married, but he was interested in one of the other residents.
Oh, yeah.
Of course, his wife didn't understand that and didn't accept it at all. So, that would be difficult. That would be hard not to.
Yeah. I had a family I had to call one time that said they were not okay with their mother having a boyfriend. And it kind of was sad because they really enjoyed each other's company.
Yeah.
And so we couldn't keep them apart. So we had to move one of them to another neighborhood. Luckily, our neighborhoods are separated. So I kind of felt bad because they really enjoyed being together.
I know.
Just really for companionship, So here's some ethical issues with end-of-life care. So I don't believe, Linda, Ohio's doing this yet, but some states have the physician-assisted suicide.
There are some states, 7 states actually, and then the District of Columbia. Chera and I have a dear friend and associate that we respect each other very much. We are so in agreement about this issue.
Yeah.
You can see where it would be an ethical dilemma.
Yeah. I recently my husband and I watched a series too. I think it was Designated Survivor. If anyone's seen that series, where one of the main characters' moms moves to visit her state, I think it was the District of Columbia, where she finds out her ulterior motive was because that state had physician-assisted suicide, and she had the medicine, and she said when it was time, for the daughter to help, and the daughter was really having a hard. I mean, I don't know. That's a tough one. I'm kind of glad we don't have to deal with that here, Linda.
No, well, and then too, it's incompatible with the physician's role as a healer and the American Association's Code of Ethics. No, I don't know. I'm sure everyone has their own opinion about this. Does anyone want to share any thoughts about this?
Yeah. So we see most of our families just choosing to have hospice, and, you know, depending on their loved one's situation as they decline, they generally sign a DNR, and they're just wanting to let nature take its course, and God, when God calls them, not to fight that or have futile aggressive treatment. The reason hospice was created was because like 80-90% of Medicare money was being spent in the last couple months of someone's life trying to do all this futile aggressive treatment, rather than just keep them comfortable either at home or wherever home may be. And just quality of life. Who wants to die trying to do all these aggressive treatments in a hospital? Like, I think we've come a long way over the last 2 decades, but
Mhm.
that's how hospice was created. So, okay, so this is just our information. We are from Kemper House in Highland Heights. We also have another division of our company, Kemper Wellness, and they have a website. I have it up there. They have a lot of really good free educational CEUs with our Dr. Nate Bergman, on, healthy eating, and not just dementia related, but how to stave off dementia, maybe push it back another 10 years, change your lifestyle, different supplements that they talk about, different ways of eating better, cognitive re-enablement, and different programs that they're doing. So you can check that out. It's very interesting. And then, of course, there's my contact information if you want some more information or to see what else we have coming up. A lot of our programs have already been recorded with the Mentor Library. So, you can go to their website. Maybe Mary can explain how to get to our programs. But I know
Absolutely.
a lot of people have watched them afterwards, probably more so than we're on the actual program. So we thank you guys so much for attending our programs that we've done through the library, and hope to see you guys in the future.